Hello and welcome to another episode of Machine Medicine's interview series, and we are honored to have Martijn Beudel here with us from Amsterdam, who I believe is a movement disorder neurologist. In first and foremost, Martijn, is that right? Perhaps you kick off by just telling us a little bit about yourself and how you came to do what you do.
Yeah, thanks for this invitation. About this online interviews. I'm Martijn Beudel. I'm a neurologist working in the Amsterdam University Medical Centers. As you phrase it, I have two interests. That is neuromodulation and movement disorders. Nowadays, most patients receiving neuromodulation do have movement disorders, but that's certainly not the only indication. I'm working here for approximately 3 years now, and we have a large volume center in which we combine state-of-art DBS care with research. We have a large team, and have a lot of interesting challenges where we're working on.
Cool. And maybe you give us a little bit of a sort of overview of how you came to work in this area. Were you straight into undergraduate medical school, or did you have a more circuitous route?
Yeah, I started my studies at a technical university, did my first year there, but after that I switched to medicine. And I graduated and did a PhD in neuroscience, which was on functional MRI. And after that, I started my training, and during that training, I was confronted with the possibilities and impossibilities of treating patients with movement disorders. And I was trained in a center in the Netherlands called Groningen, and it's also a high-volume DBS center. And was intrigued and was allowed to do a postdoc at UCLH and in Oxford, and saw the techniques, especially in London, but also worked in the group of Peter Brown and Vladimir Litvak and the clinical team at the UCLH, and I've seen a lot of possibilities and started doing research when I returned back to the Netherlands in our own team. And I was able to continue that work when I moved to Amsterdam 3 years ago.
Fascinating. So you say you did your first year was in technical university. So was that basically a sort of engineering course that you embarked upon? Yeah,
well, it was architecture, so it was less hardcore engineering studies in the Delft University of Technology, but there were some technical aspects involved in the study.
Yeah, but it didn't float your boat, and so you thought medicine would, and here you are.
It's difficult to enter the med school in the Netherlands, and it's basically a ballot each year, and sometimes you're not lucky, and the year after you can be more lucky. So that's the reason.
Got you. Partly just a sort of queuing exercise. All right, fascinating. Let's get down to some of the sort of the nuts and bolts of your research. So there's a paper that we have here that we'll use as a sort of scaffold for our conversation, if that's all right. But I guess one really interesting aspect of it, which is quite general, is that it focuses on, the title, I should say, is Acute Effects of Adaptive Deep Brain Stimulation in Parkinson's Disease. So the first thing I think would be really cool to talk about is adaptive DBS. And what is it, and why are people so excited about it in the field and outside?
Yeah, so right now, we typically stimulate patients with Parkinson's disease with 24/7 the similar stimulation parameters. And what we know is that the symptoms of PD patients fluctuate over the day. So you often see that the tremor is sometimes less severe than at other moments. Sometimes patients do feel off, as it's called. That's the motor symptoms are more severe than other moments. And what we know is that there are neurophysiological physiomarkers, as they are called. So there are signals, especially neural oscillations in the beta range, that's from 13 to 30 hertz approximately. And we see that there's a big correlation between the amplitude of these oscillations in the local field potentials, that's the potentials surrounding the DBS electrodes, and the severity of contralateral symptoms. So we think that by recording those local field potentials and quantifying them, we can better adjust the stimulation based on the needs of patients. So we know that PD patients still use their medication after the DBS surgery, typically around 50%. But we also shown that the beta oscillations decrease when patients take their medication. So we think we can make the medication and the stimulation work in synergy when we adapt the amount of DBS to the actual state of the patient. So that's one advantage, because we know that we can stimulate too little, but we can also stimulate too much. And if you stimulate too much, you can get the dyskinesias, but you can also get other stimulation-induced side effects.
Yeah. So I guess an interesting sort of aspect, which is sort of in the background of this, is that the programming of these devices can be quite challenging in many patients, I suppose, and almost impossibly challenging in some. And I guess is a nice way of thinking about adaptive DBS, that we kind of make the programming sort of algorithmic rather than kind of what would we call it, a kind of trial and error approach that we might be taking in programming today.
Yeah, you name another important aspect indeed. So there's one aspect that controls the stimulation when patients are titrated based on the best stimulation parameters. Another approach is that we can use neurophysiological signals, but also more advanced neuroanatomical features to optimize the way of stimulation. So I think, right now it's a trial and error, and we use combination of different contexts, different stimulation parameters. I think in the nearby future we can rely more on tensor imaging to see the connectome of the target structure, and more selectively influence fiber bundles that project to critical structures. On the other hand, by more rigorously measuring the neural activity surrounding all the electrodes, we can also find a neurophysiological sweet spot, and that will definitely help in finding the optimal stimulation targets. Yeah.
Okay, and so and if you were to, we've talked a little bit about what's so exciting about this. If you were to put your skeptics hat on and say, well, what are the, if you had to be devil's advocate and sort of say what the potential problems might be with adaptive deep brain stimulation, where would you start? Is it all good and no problems, or what do you think the major challenges are here, and why might a skeptic think that it may not turn out to be as impactful as some believe it will be?
So I think there are still plenty, and that's one of the reasons that not every patient is getting adaptive DBS yet. So right now we used a very basic control algorithm, which is a patient-specific power spectral density in a single frequency range. And for this study, we used beta oscillations. One of the important findings of this study, but also earlier work on correlations between symptoms and the neurophysiological signals, is that we do see that bradykinesia and rigidity can improve with applying adaptive DBS. That's not the case for tremor. So if you have a tremor dominant PD patient, it seems that applying adaptive DBS based on beta oscillations is not the best feedback algorithm.
Yeah.
So having said that, we're still in the beginning of the exploration of the neurophysiological signatures. So we might be able to find a more tremor-specific physiomarker, or a combination between neurophysiological signals or other signals. So that's a clear limitation at this moment.
Yeah, I mean, that's a very, very interesting phenomenon, right? This apparent interaction between the behavior, the oscillations, presumably, that are driving tremor, and the beta power oscillations. So is it just to sort of hash this out and get sort of clear about at least one sort of theory about what's going on here? It seems sort of relatively plausible, and I think it's discussed in your paper that that perhaps the oscillations driving tremor are actually inhibiting the beta oscillations themselves, or the beta oscillations are inhibiting the oscillations driving the tremor. Is that the right way around? And then when the beta oscillations are treated with adaptive DBS, then you suppress those, and by implication allow the unmasking of the oscillations driving the tremor, so you get the sort of seesaw effect, or I think flip-flopping you call it in your paper. So yeah, is that right? Have I mischaracterized it? And so you think that basically the solution to this will be kind of more subtle, more nuanced approaches to adaptive programming?
Yeah, so I think we know that beta oscillations are anti-kinetic in nature. So even in healthy volunteers, we have EEG studies showing that an increase in beta oscillations can disrupt motor activities, and external neuromodulation in the beta rays decreases motor velocity. So we know that by removing these beta oscillations, more prokinetic signals can come through, and tremor might be one of them. So I think we should aim for personalized physiomarkers in patients, look at the connectome of the STM, and look at the patient's specific needs.
So, and I think you discussed also sort of trying to pick up a signature of the tremors, so of the oscillations underlying the tremor, and then I guess you could, the idea would be with some kind of magic bullet, you would target the beta oscillations and therefore treat the bradykinesia, but also somehow at the same time target the oscillations underlying the tremor. But I was interested to sort of to ask you about that. Rather than trying to measure the oscillations underlying the tremor directly, what about just measuring the tremor directly, like with, say, an accelerometer-based system? I believe Boston Scientific even have a collaboration with with a company that does that uses accelerometers. A Great Lake Neuro Systems, I think, neurotechnology, one of those. So is that plausible? What's the inherent advantage to recording this stuff from or detecting these things from local field potentials? Yeah.
So I think there's a need of more clever algorithms. On the other hand, we can't even manage to suppress bradykinesia and rigidity in a setting outside the hospital. So I think we could proceed in small steps in non-tremor dominant patients to look whether we can make sure that aDBS is of any help for them.
Right.
One tricky thing for the accelerometer and tremor is that it detects tremor, but it has a certain delay. So when you see that the tremor emerges in, for example, essential tremor, you can be too late. In PD, it's often resting tremor, so that's less of a problem. But you can think of combining signals to find the optimal stimulation setting. Yeah.
I see. So maybe the first generation of adaptive DBS would be because it's sort of interesting because DBS tends to work very, very well on people that have tremor, right? Not always, but as a group more often. And so you're thinking maybe, okay, even though DBS, if I can call it sort of ballistic DBS, non-adaptive DBS, tends to work better on tremor dominant patients. Actually, maybe the first generation of adaptive DBS we should do patient selection for bradykinesia dominant patients, and give those tremor dominant patients just sort of, as it were, ballistic DBS without the adaptive element. Is that the kind of that might be one approach to?
Yeah, well, I would call it the beta-based adaptive DBS looks to be most suitable for akinetic rigid patients. Yeah.
Right. I see. Yeah. And then I guess but is it possible to measure, just because if I understand the literature from the reading I've done, the oscillations driving tremor seem to be rather more distributed. Perhaps maybe that's not the best way of characterizing it, but certainly not as anatomically localized as one might like. If, say, one wanted to just record from the STN and get some kind of measurement of tremor, I guess these oscillations are probably distributed much more widely. Is that fair?
Yeah, we know that the data rubrothalamic tracts and their cortical projections play a key role in tremor. So for that reason, that's more distributed than a single nucleus. But on the other hand, we know that beta oscillations are also omnipresent in the cortico-basal ganglia thalamocortical loop, as it seems. So we have to find the right place to interfere with these pathological oscillations.
Yes. So does this incline you to think that actually, although most people are having a surgery in which the electrodes are deployed into the subthalamic nucleus, and then a slightly smaller group with maybe the globus pallidus internus, that maybe we'll be moving into a sort of new generation of surgical targeting, where we're actually doing sort of much more specific anatomical sort of targeting than is being done today? Because is it fair to say that most patients are getting STN surgery without maybe full consideration of other possibilities, or is that not a fair way of characterizing it? We just not got the data.
For PD, I think there's sufficient evidence that the overall effect of STN is more convenient, I would say, than for a GP DBS.
Yeah.
In a lot of PD patients, when you start with targeting the thalamus or the dentata rubrothalamic tract, we often know that once they are operated a few years after, bradykinesia and akinesia become the predominant symptoms. So for that reason, we tend also for those patients to target the STN. I don't think we're going to diverge to more nuclei, but I think that within nuclei we can make better scans. Our neurosurgeons have a lot of experience here in Amsterdam with 7 Tesla, but also with DTI, and we can focus on the projections within the nucleus to the different motor areas, and I think that will become an area of interest to look at the balance between the different symptoms within a patient and find the right connectome to modulate at an individual basis.
Yeah, I guess one of the things that those kind of analyses and those kind of tools, one thing that we might need for those sort of things to work is a lot of data. And I wonder, is there? Do you think I know of one initiative in the US, which is the RAD-PD project, which I think Dewey Jamina Shahed is leading, but that's a registry to try and gather imaging data and motor assessment data across a very and many other forms of data, cognitive and speech, across 7 or 8 sites, I think, in the first instance. So, but even that seems relatively, like you're saying, your unit's a busy unit, it's 150 patients a year. If we look at other areas where these sort of data-driven approaches have been successful, like in radiology, then often data sets in there are tens of thousands, even hundreds of thousands, maybe even millions of data points of different scans. And I wonder, are we in need of that kind of data, those kind of data sets across different modalities and different patients? or do we not need it? Can we just work it out by understanding how the circuitry of the brain works, and we'll be able to build a sort of fully functional in silico model of the patient?
Yeah, I think that's it's a really nice approach in which you are working as well. And yeah, we think we can explore these effects by integrating machine learning into large data sets. We're right now setting up a database of our patients, and that combines the clinical data before and after, including the neuroimaging data, the intraoperative neurophys, in a small cohort, also the patients that receive the Percept batteries, in which we can record the neurophysiological recordings. So yeah, I think we just started with looking at these data-driven approaches.
Yeah,
I think it will definitely help, and we did already some group analyses with new commercially available software packages, and found in large cohorts of approximately 200 patients that there seems to be a sweet sphere, so volume of tissue activated that's very localized in super responders and less localized in poor responders.
Fascinating.
Yeah, so we think that is definitely going to guide us, and yeah, it is our wish to have a data set that's continuously updating itself for optimizing responses.
Yeah, absolutely. And one of the other things I think is really, it's a sort of such a basic question, but I always wonder about it is if you look in the pathological literature, for the pathological confirmation of diagnosis, you come across figures like 75% of patients that are walking around with a label of idiopathic Parkinson's disease. Is that your impression too? And is there an issue here with the kind of the phenotype? Maybe could a cynic even say, look, all the DOPA challenge is really doing is confirming the diagnosis, and a huge proportion of these patients don't really have idiopathic Parkinson's disease. They've got some kind of Parkinsonism or something, and no wonder it doesn't really work very well. Is that too crude a sort of description of the status of our sort of diagnostic confidence for this condition? And is that an area where we could really be doing a lot better in the sort of maybe even the molecular characterization of patient subtypes?
Yeah, I think the patients receiving DBS are usually seen by several movement disorder specialists. So I think the number of the larger cohorts in which the diagnostic accuracy is described not holds for the DBS population.
Right.
More than average, the patients receiving DBS did have their nuclear imaging, which confirms that there's Parkinson or Parkinsonism.
Yeah.
I think the Movement Disorders 2015 criteria are already more discriminating than the UK Brain Bank criteria of 20 years earlier. Right. And I think, we do often see poor responders, but I think less often than in clinics where PD cohorts are treated.
Right.
Yeah, and of course we want a better confirmation, and we also looking at more intelligent way of using the richness of the neuroimaging to see whether we can apply that in making a more definite diagnosis.
Yeah, I see. That's an interesting sort of idea. Yeah, because I guess these patients are typically, if you compare the average PD patient to the kind of patient that actually goes under the surgeon's knife for a DBS procedure, I guess you would be right that they've seen many more neurologists who are usually being diagnosed more than 6 or 7 years, I guess, right? And also these would be movement disorder specialists. So maybe it can make an argument that the diagnostic accuracy should and could be a lot higher there. So that's very interesting. So yeah, so you guys are already kind of trying to sort of bring some of these data sets together and sort of characterize these patients in some more detail, because I guess one of the other things about the paper that was really, as I said, I really enjoyed reading it, and it was very nice, but I guess it was somewhat typical in the sense that the numbers were rather small, and although I guess there were quite a lot of complex sort of well, not super complex, but fairly complex kind of statistical sort of approaches to try and get around some of those problems. But I guess at the end of the day, you want N to be a lot bigger. Yeah, this is you mentioned also another thing which is very interesting, which is these Percept devices. So in this study, I think you guys took advantage of the fact that these patients were having their batteries changed. Is that right? And hence why the numbers are relatively small. You can only do people that are on the table with the battery change. But now these new devices, like the Percept device, is coming out. Hundreds and hundreds of people are now walking around with Percept devices. I presume it'll become thousands. So we'll have intracranial recordings, local field potentials, potentially from these guys. So do you envisage this kind of driving change at a sort of higher velocity than we've seen to date?
Yeah, definitely. So the experiments we did in Groningen some 5 to 3 years ago were basically a different era. So we did the recordings in the OR, and yeah, since 2020, Medtronic has the Percept device commercially available, and is now doing a clinical trial, the first clinical trial in the world on adaptive DBS. Yeah, and that trial has much more opportunities than we have within the OR. So it's possible to look at patients for several months and to see whether the potential advantages are really there. And yeah, I'm delighted with the possibilities of this new era. Yeah.
Yeah, I mean, one sort of simple. I know we all hope that there's much more to it than this simple thing, but one simple benefit which does seem to be quite clear is that you can get at least equivalent clinical benefit with stimulating only about half the time. Is that right? So at the very least, battery life could be enhanced, quite considerably.
Yeah, but as you say, the cohorts so far are, I think, right now there are less than 80 patients reported in the literature in the last 8 years. So that will explode with the availability of implanted DBS devices. Yeah, we can confirm these data in more real life environments. So that's something. But I agree with you that the more energy efficient is the most low-hanging fruit in terms of upsides. So. Yeah,
but I guess one of the other things that's changing is battery technology is becoming a lot better, right? I mean, partly driven by things like the automotive industry, but just sort of generally improving. So, I mean, I guess a cynic might also say, look, you can externally charge these devices now, so really the battery is not that big a deal, because all it means is somebody has to put a little charger on their chest, once a week, once every fortnight or something. Is that?
No, I agree with you. That's not going to make the difference, but it's most easy to show that that's an upside. So, but whether it has a true clinical relevance, I don't know.
Yeah. Okay. Cool. So I'm conscious that we're coming to the end of our time, Martin, and I know you're busy, so I won't delay you for too much longer. But it would be really interesting, for some of perhaps the younger audience of these interviews to hear your thoughts on, where would you, if you were doing it all again, would you come back into the same place, or is there a set of skills that you would recommend developing for people that want to come into this area? What sort of any tips for the aspiring movement disorder specialist DBS aficionado?
Yeah. So we work together with people of many disciplines, also with grad students and master students from technical universities. We're working with neuroscience students, but also with students from med school, and yeah, one of the things I've learned throughout my PhD and my postdoctoral training is programming and to see the data yourself. And I think that's really valuable and fun to have that skill and to learn that language, which can help you to master what you're dealing with in terms of data.
Yeah.
So that's one thing that's that I often hear, but that's also helped me a lot. And for the students with a technical background, it's really valuable to be there when patients are recorded, to see how they deal with stimulation and how to help them with titrating the aDBS. So that's what I hear back from our technical students, that they are helped a lot in their studies by getting that exposure.
Yeah, this is so true. It's almost like, I just wonder, do you think it's possible? Because it seems to me there's this sort of gulf separating the kind of skills. Put it this way, it takes, I don't know how long it took you, but I know it takes many people, 15 years, something like that, to, do all their training and get their PhD done and everything, just to sort of become, you can be talking like the best part of 2 decades to become a sort of, a movement disorder specialist, right? And then to develop the appropriate engineering skills for, say, doing something like, computational reconstructions from MRI, say, or something like that. That, again, could be like 10, 15 years of training. And so is it feasible, is it plausible for there to be a generation of researchers who are, not, there's obvious kind of, occasionally there's an Isaac Newton, but for essentially just intelligent, hardworking people to develop the skills on both sides of this kind of gulf. Do you think that's plausible, or have we just got to find ways of for movement disorder specialists to work with engineers, and the two will never sort of merge into one individual?
No, I don't think the two will merge, because they have a different background, of course, but they can learn from each other. And I think there are skills an engineer has, a physician will never have, especially in terms of biomedical engineering, for example. I think it's a really nice field where a lot of people have moved different ways to come there, and they need to find curricula that can help them with both skills. So.
Yeah, I guess it wouldn't do any harm for almost anybody to learn a bit of programming nowadays. So maybe I should think that's definitely good advice for any clinician or other scientist aspiring to work in this area. Martijn, thank you so much. It's been a pleasure and interesting. So we've been able to touch on a few sort of elements of your paper, but to anyone that's wants more, I do strongly recommend it. It's a really nice paper. I enjoyed reading it. Thank you very much, and we look forward to catching up again soon with any luck.
Yeah, thanks so much more for the invitation. Bye.
Cheers.